Is it good?
Yes, yes.
Okay.
We will wait for another 2 minutes, madam, because
Yes, sure, no problem.
How the things are going?
Any other meeting was going on?
there is a neuro conference, no? That meeting probably.
Okay. So tell me one thing, it's my voice quality, is it good?
Yes, very good, very good.
Okay, yeah.
Right, can you share the slides so that you can check it out? I am Dr.
I will
Veeresh.
check it.
Okay, it's all right. Welcome, madam. I am Dr. Veeresham, academic chairman and past president of ISA Telangana State. Can you hear me?
So can you see the slides?
Yeah.
Yes?
We can see the slide.
Yes. Okay.
It is saying started screen sharing, but we cannot see the slide yet.
First slide we have seen.
First slide we have seen, but now it is not.
No,
Again,
it is
you
not
try,
now.
madam.
Okay, I will try again. So?
Yes, we can see now.
Now it is okay.
Okay.
So, welcome, madam, to ISA Telangana webinar. Please meet our President, Dr. I. Ratnakar, sir, ISA Telangana, and Dr. M. Veeresham, sir. He is our academic chairman and immediate past president, ISA Telangana. So, this series of webinars have been continuing since April 2020, and we didn't stop it in between. So, it is going on continuously with the support of ISA Telangana. So, hopefully, we'll continue this program in future also. Today's moderator is joining very shortly, Dr. Shyam Sundar. He is additional professor, AIMS BB Nagar. Welcome, madam. And then other thing is very sad to hear Dr. Suresh Kadam.
Yes.
Our ISA Nanded member and FBF member also. He died at a very young age, 52 years. And that again stresses the importance of becoming FBF members, all the ISA members. So it's a very young children also, I think.
Oh, yes. Actually, I received a call from Dr. Suresh Kadam when he was contesting for the vice president post of IMA. So that time I
He is very active in IMA, I think. IMA.
Yeah. I know.
IMA Nanded, chair and president also.
Yes.
I think 98 people died in the last 1 week in Kanpur because of MI. And they are thinking is because of cold wave triggering the MI.
So only assumption.
We don't know. Shall we start, Veeresham sir? Okay, madam. I think we can start. We will start it now. I will briefly introduce our speaker, today's speaker, Dr. Manjusha Shah, madam. She is consultant anesthesiologist at Naval Hospital, Naval Maternity and Nursing Home, Solapur, and Naval Endoscopy, Infertility and IVF Center, Sayan, Mumbai. She is a well-known academician and she is a senior anesthesiologist as well. Thank you, madam, for joining us for ISA Telangana webinar. We welcome you.
Thank you, Dr. Ramakrishna, for the introduction. Good evening, one and all. At the onset, I must thank ISA Telangana for giving me this opportunity to be a part of this webinar. And it's indeed a pleasure to speak on simulation training for anesthesia providers. I'm really thankful to President Dr. Ratnakar and Honorary Secretary Dr. Ramakrishna Reddy and team for giving me this opportunity to speak on this topic of simulation training for anesthesia providers. That is again very helpful in our day-to-day practice. I remember that when we conducted the Safe War courses in Maharashtra, that time we realized that we taught non-technical skills more, and we give more stress on the non-technical skills rather than technical skills, because most of the medical errors, they are happening because of this deficiency in the non-technical skills in India. Excuse me, Beta, the slides are not running. I don't know what happened. Yes. So as an anesthesiologist, we are involved in various tasks of patient care, which include the use of rapidly acting drugs, operating complex devices, and performing invasive procedures. But again, we demand the safety. We look for the patient safety at the same time. So this is one of the reasons that our specialty is often and always compared with the aviation industry. There is a long history of aviation industry. They are using the simulators for training as well as management skills in the crisis situation. So aviation environment, anesthesia practice, similarly, the anesthesia practice in the operating room involves multiple tasks requiring a high degree of vigilance, procedural monitoring, and decision-making skills in a dynamic, complex environment, which is also affected by the simultaneous interactions of different members of the operating team. So our field of medicine is not behind. We use the simulators in the field of healthcare. It's one of the finest uses of science and technology in the service of mankind. The simulators, they address the importance of repeated practice in order for responses to become automatic in the event of an emergency. Even I'm having that experience that in emergency situation, whatever we learn in the simulation environment, definitely it helps when there is an emergency situation, automatically we follow those guidelines and we work in the operation theater. So critical life-threatening incidents, though they are rare, but when they do occur, they have potentially disaster consequences unless the anesthesiologist is able to quickly diagnose and correct the problem. So use of simulation, it has several potential applications in medical training, and its use in acute medical specialties and its potential uses in skill training, learning teamwork, competency testing, and recruitment. Definitely it's beneficial for the professional development of our specialty in India. So it is a creation of an experience that is similar to the real world, but in a controlled environment. Please keep it in mind that simulation, it is a technique and not technology. Though it is similarly used in shipping, space labs, as well as aviation industry. It is a technique to replace or amplify real patient experiences with guided experiences artificially contrived, which evokes or replicates substantial aspects of real world in a fully interactive manner. So the theory behind is this: act, reflect, and definitely apply in a risk-free environment. Previously, we used to use animal models as well as cadavers, and even we had taken a training under the real patients. But the scenario had changed, and even when we are teaching and learning the participants, they are sitting on the other side and teachers on other side. But the things are changed, and we have this roundtable discussion in which the facilitators as well as participants, they interact, they discuss, and definitely it affects the psychological safety of the participants. It helps and in maintaining the psychological safety of the participants in the simulation environment. There are simulation labs in the most of the medical institutes, but it's a vision of Medical Council of India that stimulation we should have the simulation labs in all the medical institutes. So the first anesthesia simulator, that is SIM-1, it was described in 1969 by Denson, which was developed as an aid in learning to intubate and to induce the anesthesia. It consists of mannequin with intubatable airway, upper torso, and arms. Again, it has developed up till now that we, from the low fidelity simulators to high fidelity simulators, and most of the institutes, they have these high fidelity simulators in their organizations. So human factors that are responsible for the medical errors, and more than 70% of the medical errors that occur due to the issues related to non-technical skills than technical skills. And you're aware that there is no formal training provided for the non-technical skills in India. There are very few courses where this non-technical skill is taught in the courses. So simulation, it provides the ideal solution for the training for the postgraduates as well as undergraduates. Even it is very important to train the doctors in the rural as well as district hospitals. So we face the challenges in medical education that we know that we always say that we learn from our own experiences, but there are limited opportunities to experience these rare events and crises. You have to wait for something to happen to learn. So, and it is very difficult, the risky procedures to train the clinicians on real patients. So like use of defibrillator, cricothyrotomy, tracheostomy. So all these opportunities that we experience very rarely when there is a emergency situation. So we have to wait for something to happen to learn. So simulation, it helps, and it's safer to practice on the simulators than on the patients. They are used to teach and assess psychomotor skills as well as cognitive skills. It is used not only to teach the technical skills, but also non-technical skills such as effective communication and task management. It is useful to become familiar with new technology, to practice behaviors and strategies, to acquire routines for specific scenarios, and to reflect on one's behavior. So there are certain advantages of simulation in healthcare, that to gain experience in decision making when we face a difficult situation, it allows assessment of skills of medical person without compromising the safety of patients. It reduces the risk to the patient as well as inconvenience to the participants. Optimal manipulation of the environment allows realistic replication. And again, we can have this repeated training with the help of these simulators. Again, individual performance assessment and feedback is possible with the help of recorded events. So it is a task-driven as well as event-driven. Task-driven, that what we are using at putting the lines, arterial line placement, central line insertion, intraosseous lines, chest drain models, airway as well as CPR models. And event-driven, it means we conduct this role play with the help of fidelity stimulators. So fidelity, it describes the degree of realism and technical complexity. It is related to the level of technical sophistication of the simulator. So low fidelity or high fidelity, it should not affect simulation-based education like team dynamics, shared decision, as well as task management. As an anesthesiologist, we always look for the patient safety. And what is meant by patient safety? It always depends on good technology, good doctors, and good medical protocols. So for the patient safety and comfort during the procedure, the current standard practice, which is expected from the anesthesiologist, is by patients as well as surgeons. So it's important to train the physicians to become competent anesthesiologists to deliver a high quality and safe anesthesia. Training in actual work environment is a well-accepted method, but there are certain safety issues arising from this approach. That's why simulation has become an indispensable tool for training as well as evaluating procedural skills. It improves performance as well as patient outcomes. So it comes under technical skills as well as non-technical skills. Technical skills that again we routinely we learn it most of the workshops as well as conferences, and the combination of using drugs, complex devices, invasive procedure, that is again challenging for everyday practice for anesthesiologists. The non-technical skills like decision making part of the situation, it's even more puzzling most of the time. So sharing information, planning possible situations, good communication, it's fundamental for the safe anesthesia management. So training those non-technical skills with simulation in a controlled environment, it increases the quality of training and improves the professional development of our specialty. So difficult airway management, again, it's one of the primary challenges that we face, and it's a safety issue in practice of anesthesia. So it's very important to, if there is a failure to intubate the patient, it can increase the morbidity as well as mortality. So it's very important to train the postgraduate students as well as undergraduate students. In if there is a situation that can't intubate, cannot ventilate scenario, then transtracheal oxygenation as well as cricothyrotomy is the final option in case of difficult airway management. Again, ultrasound guided regional anesthesia, it is an effective tool in regional anesthesia, which is not only helpful for adult, but even it is helpful in pediatric patients. 4 broad uses of simulation in obstetric anesthesia: improvement of technical skills, non-technical skills, individual clinical competence, and the safety of the clinical environment. The skills such as epidural anesthesia, major hemorrhage, estimating volume of blood loss, and maternal resuscitation that are effectively taught via simulation. And similarly, videotaped simulation sessions can be used to teach the team communication skills. Again, you know that cesarean deliveries under general anesthesia has significantly diminished over the past few decades. So educators have advocated to use simulation training to fill this gap in training of the residents. There are standardized scoring system for objective assessment of the residents' performance of general anesthesia for emergency cesarean delivery on high fidelity simulator. The residents were exposed to repeated simulation-based training programs to perform general anesthesia for emergency cesarean delivery. Again, bronchoscopy is a useful skill for anesthesiologists while dealing with the complex cases involving difficult airway, lung isolation, and when we are working in the critical care unit. In addition to the cognitive ability, excellent manual dexterity, and hand-eye coordination that are needed for the meaningful results after the bronchoscopy. Again, there is an increased use of transesophageal echocardiography and transthoracic echocardiography intraoperatively, and simulation is a helpful way to teach basic concepts of transesophageal echocardiography. And again, it has shown to improve cognitive skills like normal echocardiographic anatomy, structure identification, and image acquisition. Again, coming to WHO checklist, that as I already told that during the safe OR workshops that we conducted the role play, how to go with the WHO checklist. It has decreased the mortality from 1.5% to 0.5%, and it is recommended in underdeveloped countries. It is divided into 3 groups like sign in, time out, and sign out. The whole team need to be a part of this exercise, like nurse as well as anesthesiologist and surgeon. So nurse will take the lead to sign in for the and anesthesiologist has to respond. And again, for timeout and sign out, the surgeons as well as anesthesiologist has to respond while checking the list. If you find something wrong while checking the list, it has to be addressed immediately before proceeding to the next step. So coming to non-technical skills. Non-technical skills, it means behaviors of the means it is a behavior in the operation theater, which is not related to medical expertise or drugs or equipments. So a team of anesthetists and psychologists, they developed anesthesia non-technical skill system. The framework describes following 4 categories of the skills that are very important, like situation awareness, decision making, task management, and team working. This framework gives an instrument to assess performance during various resource management courses in anesthetic simulation. So what is ACRM? ACRM is the Anesthesia Crisis Resource Management Program. Again, that concept has come from this aviation industry. They developed this crisis resource management program during that 747 Boeing collided on the runway, and how to manage these skills. So they developed this CRM, and this is again adapted to our medicine field by GABA which is known as the Anesthesia Critical Crisis Resource Management Program. So these are the core concepts of this ACRM, like maintain the situation awareness. It involves understanding the content and significance of elements within the given environment. Know your environment, you and your team, distribute the workload, call for help, communicate effectively. If we come across with the, like for example, in intraoperative, we face the patient develops arrhythmias. So the anesthetist has to act as a leader and distribute the work. He has to call for the help and communicate effectively with the nurse as well as surgeon. So he can ask for the antiarrhythmic drugs and arrange for the defibrillator. He can ask these things to the nurse and communicate effectively. It should be a closed loop communication. So, and can anticipate and plan according to it. And use cognitive aids to assure completeness. So improved communication in the teams, it had changed the practice positively. A good team requires individuals to work together to achieve the shared vision. What makes a team to function well? It's good leadership, good communication, clear vision of the objectives, means and commitment to achieve these objectives, supportive and respectful environment. Good leaders have well-defined attributes such as clear communication, focus, honesty, and enthusiasm. High-performing teams are flexible and trained together. This helps develop situation awareness and a shared mental model for all the members of the team. And it's again important that you have to keep the patient at the center of your vision. Communication again is a part of these non-technical skills, which is essential for good outcome in an unusual or crisis situation. Sharing your thoughts with the team and direct communication with named individuals, that is very important, and the closed loop communication. If there is a cardiac arrest that can occur intraoperatively and you ask for the sister, you take her name, that someone like if she's Radha, so ask Radha to give 1 milligram of adrenaline and flush with 20 cc normal saline and raise hand. And again, she should reflect back to you that 1 milligram adrenaline given, flushed with 20 cc normal saline and raise hand. So that is the complete loop. So it's very important that this complete use of closed loop communication. That is again, it it helps to improve the outcome of the patient. Situation awareness, it means paying attention and knowing what is going on around you. Good situation awareness, it includes predicting the immediate and future impact of your own or team's actions and anticipating the complications. So good situation awareness is developed by continuously gathering the information, recognizing and understanding what you are seeing, and again anticipating and planning according to the situation. It is a team activity and is essential for effective decision making in the operation theater. Each of us may have our understanding about what is happening so that we can say it's our own mental model. But the safe and effective teams, they communicate with each other so that they develop a shared mental model and strengthen the situation awareness of the team, which helps to make good decisions as a team, counteracting the overall confidence, mitigate the impact of an individual if they can make an error, and again anticipate the problems and reduce the stress in the operation theater and definitely it avoids harm to our patients. Good decision making it requires good technical skills as well as non-technical skills. Decisions are often made under pressure. So it is important to quickly assess the situation, identify options, balance risks, make a timely decision, and to enact this decision, communicating this effectively with the rest of the team. The SBAR tool, it is very useful to aid the communication and assist the rest of the team in reaching a shared decision. SBAR is a situation, background, assessment, and recommendation. For example, the situation is that the patient in the recovery is bleeding. The background is that she underwent cholecystectomy. After assessment, she is having tachycardia, her heart rate is 140, there is hypotension, blood pressure is 60/40, and she is looking frail. So the recommendation is that we need to bring her back to operation theater. When the decision is made, particularly under pressure, it is important to re-evaluate the situation constantly to make sure the initial assessment was correct and the right decision was made. Again, coming to team debrief and debrief, that is very important, but I don't know how many hospitals that they are following these team brief and debrief. A team brief done at the start of the day and debrief at the end of the day, that improves the way the operating list runs and can be a way of driving improvements locally. So successful implementation of a team brief, it requires surgical leadership and support from the hospital administration and the team to understand the benefits of the briefing. Again, situation awareness that is affected because of the stress, fatigue, and distractions. And one more thing is that conflicts in operation theater. So how to avoid these conflicts? These are the best prevented through appropriate leadership, application of departmental policies and procedures. Working relationships should be based on trust and respect. No one is right all the time. So to resolve a dispute, avoid making personal comments, be constructive, and confine contribution to suggestions for resolution. Again, very important part of to conduct this morbidity as well as mortality meetings that we taught when we conducted the SAFE courses in Maharashtra. It is very important to conduct these regular meetings. I don't know how many hospitals they are conducting such meetings. It's an opportunity for the clinicians to discuss errors and the adverse events in an open manner. They review care standards and the quality indicators. If someone feels that to make some changes in the healthcare system, they can make the changes after the meeting. The meeting, it provides a learning exercise for the whole team. It should be used to effect positive change for better patient care. It should not be used to blame individuals inward. So to conclude, anesthesia practice is a high-stakes practice. Critical events, they occur from time to time, or it can happen anytime. The errors, when they occur, are due to non-technical skill deficiencies. And of course, it's very important to take the formal training, which is required to improve the non-technical skills. And simulation is the key for to develop these skills. And again, there is a bright future for training the budding doctors by improving their skills as well as reactiveness, at the same time reducing the risk for the patients. And it's very important to impart this training at the district through the doctors, those who are practicing at rural as well as district hospitals, so that it will help in the patient safety, as well as it will help to reduce the morbidity as well as mortality. So these are some of the references where we actually there are some studies conducted and published how this simulation training is useful for those undergraduate as well as postgraduate students. So thank you for patient listening. Again, I'm really thankful to ISA Telangana, Dr. Ramakrishna Reddy, Dr. Ratnakar for giving me this opportunity to be a part of this webinar. Thank you so much.
Thank you, Dr. Manjusha ma'am. It was a very nice lecture to hear. And these briefing and debriefing should be followed routinely in all the hospitals, and in teaching hospitals we are doing this mortality and morbidity meetings, but other hospitals I don't know, because they don't get much time. So hopefully the things will improve slowly in India also.
Yes, yes.
Uh,
It's a time pressure.
yes.
Because of that, actually debriefing is not properly conducted in
Yes,
many
yes.
hospitals.
Because when I was working in NHS England, it used to happen every day, early morning and at the evening also. But slowly India is also they are picking up the things. So I would like to invite this today's moderator, Dr. Shyam Sundar is here. I would like to introduce him. Shyam?
Sir, am I audible, sir?
Yes, yes, yes.
Yeah, I'm
So,
extremely sorry,
please take
sir.
take over the session. Yeah.
I'm extremely sorry, sir, because
No,
of
no,
some
it's okay.
not able to join in time.
Mhm.
Thank you, Manjusha madam. It was an excellent presentation. Yeah,
Thank you.
as I said, like I don't know about the other areas, but in institutes we are regularly following WHO model, like debriefing, briefing, as well as team timeouts in the beginning before shifting the patient, before screening session,
Yes.
so that it can like familiar with each other. And many times there are certain things will happen, like once we after induction, many times surgeons come to know there is particular instrument is not available, or particular like suppose they're planning for some kind of orthopedic procedure, the appropriate size of equipment is not available. So those incidents can be like a surgical checklist or pre-induction, pre-anesthetic, pre-incision checklist can help us to overcome all these things. Not
Yes.
only that, surgeons never will come in time. So mandatory in reinforcement of like this checklist, unless the surgeon comes, we don't ship the patient inside the, like I'm talking about AIMS BB Nagar. So in those, when I was in cardiac thoracic surgery, same thing, only junior most resident will come, faculty won't come. So once we started implementing these practices, so now at least we can see some surgeons coming in time. Unless they come, we don't start. That's one advantage of. Apart from that, simulation, as you were mentioning, the simulator training now, at least India, it's picking up with the advent with the, like most of the institute now they have their SimMan or those kind of like echocardiography simulators available. ACLS, BLS is very widely available.
Yes, yes.
Those probably implementing, like I should take initiative to implement those things in the either physical curriculum or some kind of mandatory things can help us much more education of the student. Not only that, like periodic quality assessment, as you rightly mentioning in the talk, that how safe we are can be easily assessed by the simulator, like PG's outgoing or during senior residencyship, or even treating patient. Like now recently, PATH, one is the organization of USAID program. They are also conducting simulation programs in critical care where they are preparing 30 routine scenarios like ARDS or hypoxia, and what is your ventilator settings, whether the settings are appropriate or not. So those things will be objectively assessed based on the performance of the individual.
Yes.
So these are the areas simulators are very helpful. Probably, as you said, as it is a PG oriented session, PGs can be better trained. That is what I am thinking. Yeah. Any other comments from the senior faculty?
Yeah, I would like to comment. I'm Dr. Veeresham, academic chairman. Actually, the simulation, are you able to hear me?
Yes, sir.
Actually, this briefing and debriefing is not there in medical faculty people, but it is existing there in staff nurse cadre. Whenever they are taking the job, which patient to be given, which drug at their level, and which to be not given, and they will be giving a charge before they leave. But it is not existing in our faculty. It is because of fear or something, seniors are asking or like that. But that curriculum of physical, at least physical curriculum of debriefing and briefing is present in nursing cadre. And especially we are experiencing as a faculty when we are in the wards and all those things. Am I correct? but it is not there in our medical teaching faculty till now. Probably getting tuned with the newer trends, but it is very much essential for the life saving and technical errors. It can be corrected, and our technical errors will be in danger to the life. It may be not noticed, but in future it is a must for everybody to have this closed loop communication and all those things.
Yes.
On that basis only in India, there are AHA guidelines for BLS, ACLS, like that. It is there, but it is practicing. Those are only the trained. Every system like a closed loop communication, briefing and debriefing, everything is there in ACLS program. So I think it is better if we practice it. And I would like to even how they are doing the one demonstration of ventilation or something, whatever Shamsundar told is correct. So ARDS simulation, every procedure there is one simulation training, then they will know. I think this is very useful topic, and we have to go ahead and we have to increase the simulation technology, and if not even physical communication, or it is very, very important. Even if simulation, that habit is very much useful for essential for good services in the medical field.
Even we conducted workshops on the safe surgery as well as safe anesthesia in rural areas. We involved medical officers from those who are working in district hospitals at PSC level, and we gave them the this type of training, how to go ahead with how to do briefing, debriefing, and all those things. So even in safe courses that we conducted in Maharashtra, in a few of the medical colleges, where we involve all the faculties from the medical colleges. And this Safe for course, it was a 2 days course, and we taught all the non-technical skills in the Safe for courses. Technical skills, of course, we discussed about that, but we stressed on these non-technical skills, WHO safety checklist, how to resolve the conflicts in the operation theaters. So we conducted the role plays, like two surgeons and anesthetists, they are quarreling, like it was like that. And again, how to conduct these mortality and morbidity meetings. It's very, very important that to follow again in all the hospital setups, that is going to develop this and improve our specialty in our country.
Any students have any questions regarding this, like regarding about training centers or any other related to simulation?
Deepra sir, would you like to add anything?
Sir, madam, are you having any videos of this? Any one video
Yes,
with you?
actually, I tried to involve these videos in my presentation, like how we work before the training and how we get improved after the training. So, but I tried, but there is some technical problem, and these videos, they are not running. So that I skip those videos.
Okay. Thank you.
And one more thing, briefing and debriefing, like what we do in our AIMS Bibinagar is, like tomorrow, whatever is the list, one day before, like first case, what should be done, second case, and prioritization of the cases. Sometimes surgeon's case post 1, 2, 3, 4 with haphazardly. We will tell them, take the what is the first case, what is the second case. Suppose difficult intubation is there, we'll try to keep fiber optic bronchoscope ready in advance, because it will be 2-3 other OTs will be there, or video laryngoscope or ultrasound sometimes, depending on the need. Like otherwise, it's getting delayed to get a machine early in the morning. So we start by 9 o'clock, but the ultrasound machine will come around 9:30. So briefing one day in advance, especially for operation theater related things, can help like better improvement and time management of these things. And debriefing can be done at the end of the same day. The next day, briefing can be done one day before. That one thing we are following in AIMS. Any other faculty, sir? Anyone is following? Madam Vibha, madam, is there any briefing and debriefing in your institute, ma'am?
Hi, Gauri.
Yeah, hi, how are you?
Hi.
Nice presentation, Dr. Manjusha. I really enjoyed it. And what I really liked
Thank you.
about it is that we are taking it to the rural areas. And I really appreciate the safe work courses that you've conducted. And I think it's all at the level of initiation. People should be motivated enough to do it. Am I audible?
Yes, yes, ma'am.
Yeah. Okay. So I think people should be motivated enough to do it. Otherwise, I think protocols of how to do are all there. It just needs to come into practice. So we have also initiated these protocols in the sense whenever there is a difficult case, we brief the team about what to do, what is our plan, where is the equipment, and after the case gets over, there is a debriefing again to make sure that everybody
Yes.
did not have anything else to add on to. Because sometimes when there is a critical situation, some people might have thoughts, but they may not be able to vocalize. So I think it's important that we debrief and listen to everybody in the team so that we can get more input, so that we can make better preparations for the next time. It's really nice that ISA Telangana has actually wanted to take up this topic, and this is one way that we can really improve awareness on this topic. Thank you.
Thank you. Thank you,
Thank
Gauri.
you, ma'am.
Thank you, Vibha.
Sir, Deepraj, sir, would you like to add?
Thank you.
Yeah, good evening. Good evening. A nice presentation, Dr. Manjusha. I'd like to bring into the one fact what you have already mentioned is more and more workshop to this effect, because we have workshops all concentrating mostly on technical aspects, airways and ventilators and pain management and all those things. But as far as communication skills or the operation theater management as a routine, if we can organize more and more workshops, probably that will help in this endeavor. And secondly, according to the NMC guidelines, these high fidelity skill labs is very much required now. One is the general skill labs where all the students will come. One is the departmental skill labs. What we are now developing in our hospital is the departmental skill labs. High fidelity mannequins are there, which will train the people in this technical aspects of it. You can tell. There are really very nice mannequins are there. Recently, Leaderly has did a workshop at our place. Really marvelous to see those mannequins simulating any situation there. And as you said, it's always the communication which is more important, which goes a long way in having a successful success list at the end of the day.
Yes.
Thank
Very
you.
good.
Thank
Yes,
you.
sir. As you suggested, many MCA guidelines recommending for private hospitals keep some kind of simulation.
Right.
The problem is costly, sir, like 2 to 4 crores minimum.
Yeah,
Significant one.
it is there. But now they have made it compulsory for every medical college to have a skills lab, a general skill lab with this specification, and a departmental skill labs, smaller.
Yes.
And Dr. Ratnakar, sir.
Very nice presentation, Manjusha, madam.
Thank you.
And this simulation is right from anatomy and physiology to it is including in almost all departments. And being anesthesiologists, we require more and more skills to learn. And I like that point. That is anesthesia, non-technical skills, ants. that is a very interesting and important from the theater point of view, because non-technical skills are almost equally important, I feel. And it's a very nice presentation from your side. Thank you.
Thank you, sir. Thank you.
Any questions from the students?
They all understood it very well. So no questions.
Conclude.
So in all the medical colleges, you follow these non-technical skills. How is situation? I mean to say whether the simulation, these skills, they have these labs and simulators, but whether they follow these skills or no, I have no idea how many colleges they follow it.
I think very few, very few.
Yes, yes.
Yeah, I think it is underutilized. So I think, sorry.
Yeah, under it. Equipment is there also, they are not utilizing properly. It is in infantile stage, basically. A newborn and infantile stage, it has to grow up. Adult stage means it will take time. Continuously, what the questions are told is actually correct. Continuously, you are going on workshop or educating yourself, keeping some time. Dr. Shamsundar already told, tomorrow some cases are there, we will brief tomorrow what to be done for the each case. And this has been happened in Usmania General Hospital. They are only limited if they give the cases for the OT, list of the cases. First case should be on the table on first case by 9 a.m. That was the protocol. And that communication should go to all the postgraduates and the faculty of the Usmania General Hospital when you are as postgraduates. That was there since long time, but how it is there every day, how is the communication? People are something deviated from this, but it is always better to have a very good recovery and very good without any disastrous events. Especially our anesthesia department requires a lot because we are very much related. Already, Madam told it is usually in aviation industries where the that is that RC risky areas, risky time, what to be done. That is very important, and it happens always in our departments on the land. I think that is the thing. Thank you. And a very good presentation. I think it may give good awareness in future.
More and more workshops should want to come up in simulation.
Yes, yes. Even my experience that while conducting all these workshops like safe anesthesia, safe surgery, and safe OR, we learned so many things. And even that, again, it's really helpful for me, even in my practice while in emergency situations. I mostly work in obstetric anesthesia, and so you know that it's very critical situation that occur in obstetrics. So it helped me a lot. So how to go ahead with, like, we applied mega code with closed loop communication, how to act as a leader, and how to communicate with the team which is present in the operation theater. It helps a lot. I mean to say, it improves the patient outcome. Definitely it helps.
Yes, ma'am, because
Madam, one or two videos to add to your topic, then it becomes more.
She is unable to play that. That's what she said.
Okay, thank you.
yes, sir. Today we had a class about eclampsia, and we are emphasizing like how the checklist will be helpful, especially when the cardiac arrest with pregnant women, eclampsia management. These are some really interesting cases which very rarely we come across these cases. At least simulation in advance can help us improve the patient safety and outcomes. Sir. With that, any other? If there are no queries, can we conclude, sir?
Yes, I think so. Yeah.
Thank you. Thank you, one and all, and especially thank you, Manjusha madam, for making this and for delivering excellent lecture.
Thank you. Thank you, madam. Right.
Thank you. Okay.
Thank you.
Good night.
Bye. Good night. Good night.
Thank you.
See you.